to your seat. It's just like the movies. Grab a little bucket of popcorn and come back over to this side of the fence, and we'll get started with our last panel of the day, which is a maternal and child health panel discussion. And again, we'll have 3 presentations and a discussion. I'll tell you right from the start that one of our presenters, Professor Ashley Butler, is from Houston. And as such, she's unable to be here in person, but she graciously agreed to participate online, despite having been affected by Hurricane Harvey. Remember Harvey was last week, right? This week is Irma, last week was Harvey. So she will be participating online. But before that, we have 2 other presentations, and the first presentation will be You Should Treat Me Like Glass, What Women in Big Data Tell Us About Gaps in Women's Health and Healthcare. Lois McCloskey is Associate Chair of Community Health Sciences and Associate Professor of Community Health Sciences here at Boston University. She's been dedicated to the health care of women and infants since spending time in Nepal as a community health worker over 30 years ago. She co-founded the Women's Health Committee of the MCH section of the American Public Health Association, and since 2010, she's led the successful renewal of an award from HRSA, the Maternal Child Health Bureau, for an MCH leadership training program and center of excellence. Her work has been supported by the Boston Public Health Commission and the Kenneth Schwartz Center, the latter to use theater to enhance patient-clinician communication. She also has support from the National Institutes of Health, most recently to study a gap in the care of women with gestational diabetes that I think we may hear some about today. Professor McCloskey.
Thank you. It's an honor to be here and to help wrap up this really rich day.
Ashley, are you there?
I would like to start by having you
No problem.
shout out.
I just want to make
take
sure
a
that
moment
you're
to think
hearing
about
everything
glass,
okay.
some of the qualities of glass,
Okay,
before
great.
I
All
tell
right,
you a
I'm
bit
going
about
on.
Nicole, who inspired the title of my talk. Different kinds of glass. What are some of the qualities? Delicate. Hot. Sharp, it can be. Brittle. Sealing. Oh, good one. Yeah, right. I'm going to throw out strong. Some glass is really strong. Stained glass, it's stained, it's layered, colorful. It also really takes and requires a lot of care and attention and is, in some cultures, passed down through the generations. So Nicole, I'm going to go back for a moment. Nicole was the first woman we interviewed back in the early 1900s. There we go. That would be the 1990s. When I first moved to Boston and was asked to direct the case-by-case infant mortality review for the city of Boston. Nicole was 30 years old. She was a Jamaican-American woman. She had had 4 births. 2 of them were stillbirths, and 2 of them were live births, also premature. She had a job at a university she considered to be extremely stressful. She was an office manager. She said students yelled at her all the time. And she had experienced child abuse, which she talked to us about in our interview. She had a very good partnership with her boyfriend as she got pregnant this time, but this baby died on day 1 at 500 grams. And this is what she had to say when we asked, what might have been different during your experience as a pregnant woman? Sorry. So I'd like you to read it. I'll just call attention to the highlighted, if you can see it. So they should treat me like glass, like I'm going to break. Also, they should try to set up support systems that help people like me that don't just work against them. Because it seemed like everything was for the women that could carry the baby 9 months. I just wish somebody would have believed in me a little more. It was like they cared, but not enough. So this very particular narrative has stuck with me for 25 years. So I want to draw today on two clusters of studies, one bookends of my postdoctorate career, one at the very beginning, this one on racial inequalities and infant mortality in Boston, and the second, women's chronic illness and the risks it confers and what we do about it after pregnancy complications. And I want to ask, have we been listening to stories? And I mean stories from data, as well as stories from people in communities. And these two really big themes have pop out at me and have for 25 years in different work I've done. One is that risk and resilience, I would add, crosses life stages and generations. We know that. The women who talk to us and tell us that, and leads us to think about the life course approach, or should be thinking about it. The second is that our systems, despite all we know from these stories and data, break down at every transition and are completely fragmented with many, many missed opportunities for prevention. So the question of the day is, has anything changed? And in fact, if not, how can change actually happen? So the life course perspective is a framework that we in MCH and others, it's been mentioned before today, gives us the theory behind this kind of longitudinal approach across life stages of people's lives, trajectories, cumulated stress over time and its impact, and then, as others have mentioned, these critical sensitive periods. And in maternal and child health, those certainly involve birth and puberty and in between births and aging and all of that. So problem number one, infant mortality in Boston, early 1990s. When I was a newly minted DRPH from UCLA, I moved to Boston, and this headline hits the news. It wasn't just once, it was a series of articles in the Boston Globe, and it was at a time when black infant mortality in our city and others had reached 4.5 times that of white infants. And this series of Globe articles made it a hot, hot political debate. There was a lot of contentiousness. Whose fault is it? I mean, really kind of ludicrous sort of political debate around it. But it also spurred some pretty important work. And I, as this newly minted doctoral person from California, a youngish white woman, was asked to take charge of this infant mortality review where we went through every case. So I can say more in the discussion about what that was like and what my sort of position, my privilege, my whiteness meant in this context. But now I just want to say that the process we went through was a layered approach, I might call it, be so bold as to call it participatory action research. It certainly wasn't CBPR per se, but we collected stories, and we collected stories that were told in medical records, told by women in in-depth interviews, and we synthesized those stories, and those were then reviewed by what we called case review teams, but they include people from community-based organizations from all over the city, and it was my privilege to listen as these conversations based on cases would happen with tenant associations, their people from youth development organizations, lots of grassroots, as well as chiefs of OB/GYN, for example, sitting at the same tables. And to figure out what was the web of causation in that person's life on a case-by-case basis. What were the systems failures that we could point to and then make recommendations? Those recommendations and analyses were then brought to a higher level of policy review team, which was also incredibly bunch of diverse stakeholders, from insurers to, again, clinicians, community coalitions and organizations attended, as well as some patients, some women who had, in fact, whose babies had died. And together, the idea was to develop solutions and then to support community-based action. So that was the model. These were themes that came up, probably not surprising in a way, but and this is 25 years ago. We learned case after case after case that fragmentation and discontinuities in women's health care over the course of their lives had in some way contributed was on the pathway to this particular death. There was severe social risk that was completely, apparently, unrecognized by our healthcare or other public health programs, and recurring unintended pregnancies, I'll use quotes around that, half of which were preceded by sexual abuse and trauma. And last, this should be in red, a sense of being disrespected was reported by about almost 40% of the women in the study. And I point to some of the ideas for interventions. This is just one very quick example of what the city, and again, I was sitting at the city health department in an urban health institute, and this is one thing that came out of this work, and there are many others, but a women's health demonstration project, which this is about how to try to change the way healthcare is delivered to women. So it was women-centric, but I want to say it was also really for women who had already become pregnant, and then the 3 years after that. The community health worker was the hub of the team. Providers received anti-racism training, and the core idea was that women were inspired to become really central in their own health and in healthcare conversations with their providers. So I list some of the challenges here. I can say more about it. This did not produce evidence, per se, scientific evidence. It did produce some practice-based evidence. So I'm going to move ahead to the second problem, chronic illness after pregnancy complications. This is what I'm working on now with my colleagues in the room that I'll mention in just a moment. But the case in point is gestational diabetes and its relationship to women developing type 2 diabetes later. But before I go into that, just a note here. Carolyn Clancy in 1992, again 25 years ago, wrote this JAMA commentary, American Women's Healthcare, a patchwork quilt with gaps, noting the gaps especially that happen because of the way in which reproductive care is siloed from every other aspect of healthcare for women. So 25 years later after she wrote this, we know a heck of a lot more from neuroscience, from social epidemiology, from epigenetics, about, in fact, the risk ratios, the relationship between pregnancy complications. And they are big. The risk ratios were quite remarkable in this BMJ publication, one of the early ones in 2002, between pregnancy complications like gestational diabetes, preeclampsia, low birth weight even, and heart disease later in life and diabetes later in life for women. But it's only recently, in fact, despite the overwhelming evidence, that maternal fetal medicine, OBGYN textbooks are actually talking about pregnancy as a window to future health for women. And beginning to turn the wheels about what that means for working in the full context of women's lives, social and biological, over time longitudinally. Here's why GDM, or gestational diabetes, is so important. And I'll just point to one of these, or two of these facts. 60% of women who ever had gestational diabetes go on to develop type 2 in 10 years. And we do not follow up. With GDM, we do not, despite guidelines, very regularly follow up with glucose testing after pregnancy. And we know in a more general way from others that there's a general lack of primary care among women after pregnancy, both Medicaid and commercially insured. So, a cluster of studies that we've been engaged with here. The first was R21 from NICHD to look at the reasons for this really poor follow-up. And it was a qualitative study engaging both women and providers. A quick look at some of the themes we found, perhaps not surprising when you realize the weight of diabetes in communities. This was at BMC here, low-income women. Receiving this diagnosis is just horrendous, given what they know in their communities and their families. The fear kind of overwhelms them in general. So that's one of the predominant themes. And I want to go ahead, though, to this last one, because the topic here today is why don't we follow through? Why can't we, for healthcare for women, and I would say it probably applies to others as well, have a continuous life course model of healthcare? And Alicia, this is a woman, African-American woman who was 28 years old with GDM. This is what she had to say when her pregnancy was over. She wanted a postpartum test, she got it, and her result was negative. I don't have it now. I can tell you I was so happy. I feel like I have something heavy, and I throw it now. So this profound sense of relief that this awful disease, in fact, isn't really a problem anymore. There's not a sense of future risk. So we're now looking at big data to study the same issue, but in a very different way. And here's where I want to call out my colleagues, Judith Bernstein, who's the PI of this R21 from NIDDK, and Myrita Craig, who is a wonderful program manager, and then you can see the other clinicians who are from BMC, OBGYN, and family medicine. We're working with Optum's lab data, and this is an amazing opportunity for us to look back and look forward, to take a longer-term view than other prior studies have been able to do at the extent to which women with gestational diabetes, as a case in point, are followed. Both with testing for their glucose levels and for transition to a healthy primary care relationship where diabetes and its prevention could be attended to. So we had 12,622 women continuously insured, so they have that benefit. And even so, what we have found, and this is just a blip of our evidence to date, by 1 year, just almost 14% only had a visit with a primary care provider, and half go on to have another GDM episode, which of course then increases their risk for type 2 later. So again, I ask, is anyone listening here? I don't mean you. Here's a map, just a quick example. We're mapping follow-up care for these women. And I guess most astoundingly, what we find is that the greatest predictor of any type of care, a primary care visit before the pregnancy ever happened, in the year before, is a very powerful predictor of what kind of follow-up will happen afterwards. A threefold likelihood that she will get follow-up care after pregnancy in that very high-risk period for type 2 diabetes. Now, this might not be, whoops, sorry about that. This might not be surprising in a way, but it is a very sharp reminder of the importance of continuity and the primary care kind of preventive health relationship that precedes that needs to precede pregnancy. So I'm moving quickly, and here is where, in a way, given the context of our conversation today, we want to take this work forward into practice and into a community-based participatory research model. I'll call it that, albeit not in the exact sense, I think, the perfect sense, which Nina spoke about earlier, but certainly applying the principles. So we have just received, yay, as of right now, a PCORI conference grant to do this work. And think of it as, and our NIH grant supports it as well. I'd like you to, the conference that we're going to be holding in a year is called Bridging the Chasm Between Pregnancy and Women's Health Over the Life Course. And our argument is that, it's time to do something different. What we're doing is not working. Things haven't changed in my career lifetime and long before that. So it's time to be far, far more collaborative. This is a 2-day conference, and briefly, it's innovative. We're bringing people from 40 to 50 only, from diverse stakeholder groups, mostly national, some international, scientists, community members, patients, advocates, policymakers, clinicians, and health system designers, okay? So not many, but all those stakeholder groups interacting for 2 days. Here are the partners we have engaged on our leadership council. They will all be at the table as we plan the conference with equal say. Black Women's Health Imperative and Diabetes Sisters are right now our primary community member organizations. And you can take a look at our other partnerships in health design, health policy, et cetera. The first day is going to be a storytelling day. And everyone there, from patients and community members to clinicians and scientists, are going to do improvisational theater with Alan Alda. He won't be there, unfortunately, but he has a center called the Alan Alda Center for Communicating Science. So we will all be trained in using improvisational techniques to tell our stories in ways that have the most impact to different audiences, including policymakers. And we'll share those stories from life experience as well as from our science. And in day 2, then, have multi-sectoral, what we're calling an innovation cafe, built on the World Cafe model, to come up with creative solutions, but in a very particular way to develop research and action priority agenda, which it's going to be a very busy 2 days, which we then will publish, yes, in the academic world, create a website for the much broader world with our leadership council helping us build this national network to get word out and build collaborations, and then develop a national strategic agenda for research, policy change, and for community action. So we're hopeful. This money's just come in. It's undone work, but we're looking forward to it, and we'll really rely on this collaborative, this much more engaged collaborative process. So I'm just going to wrap up by saying that here are a couple of kind of lessons that I'm taking away from my work and from the day. Of course, listening. That's been talked about all day. And I think narratives, stories, transform the way we see the world. Just a few stories have changed the way I understand my data. I understand the problems I'm working on. And that leadership is all about, as we sit in the academy, our leadership is really about collaboration. So I want to go back and, I had a slide. I think it got left out of this version on CBPR principles. Will we in 10 years look back and see that Nicole, someone like Nicole, might be able to say that she was treated like glass? Thank you.
Okay, Larissa Jennings. Hello, Professor Jennings. She'll be talking about microeconomic interventions to prevent HIV in vulnerable young women and adolescents. Larissa Jennings is Assistant Professor of International Health at Johns Hopkins Bloomberg School of Public Health, and for over a decade, she's studied the role of economic strengthening interventions on HIV and other sexual and reproductive health outcomes in resource-poor settings, and reported on that in over 30 peer-reviewed publications thus far. In an NIH-funded randomized controlled trial, she's examining the efficacy of a micro-enterprise intervention on HIV prevention among high-risk African-American young adults who are homeless, out of school, and unemployed. She's also studying such interventions among Native American adolescents and Kenyan urban youth. Professor Jennings.
Okay, hello everyone. So first of all, thank you so much for giving me the opportunity to share today. It's been such a privilege to listen to the previous talks. I've changed my title just a little bit, so I'm going to be talking today about an intervention trial that we have set to start in early 2018 in January and February in Baltimore. And it actually involves young adults, so young women and young men. And you might be thinking, well, this is the maternal and child health section. And that's true. So initially, a lot of my work has been in sub-Saharan Africa, where I was focusing on maternal and neonatal health. And in doing so, I got pulled into HIV prevention because we wanted to keep mothers and newborns healthy, and that meant preventing HIV. And then eventually, preventing HIV in moms and newborns meant preventing HIV in couples and communities and adolescents. And so I've been, over the last, I'd say 10 years or so, I've been working backwards and now focusing on HIV prevention, not just in sub-Saharan Africa, but also here in the US. And primarily working with young adults. And this work that I'm going to talk about actually started looking at not only young adults, so 18 to 24, but also adolescents, 15 to 17. But because we have what I'll describe later, this microenterprise component, it just looks at young adults at this point. So for those of you who have talked earlier today about HIV, you are aware of a lot of this, but I wanted just to give you a little sense of the multi-layered experience and burden of HIV in the community that I'm working with. So when we think about the US, there are 1.1 million people who are currently living with HIV, and another 50,000 are newly infected each year. And African Americans, although they represent about 12 to 14% of the population, make up about 46% of HIV diagnoses each year. And the rate of new HIV infections among African American adults is 8.6 times higher as compared to non-Hispanic whites. And so thinking of America as one community relative to other regions of the world, when you drill down to where I work in Baltimore City and thinking of that as an even smaller community, so Baltimore City comparatively to other metropolitan areas in the US ranks 5th highest in the rate of new HIV infections. And again, within Baltimore City, 81% of the HIV diagnoses were among African American adults, many of them young adults, so between 20 and 29 had the highest proportion. And HIV prevalence among African Americans in Baltimore City is also quite high. So the actual prevalence is around 3%, and that's over 8 times the national prevalence in the US. And according to the UNAIDS definition of a generalized epidemic, Baltimore would be, among the African American population, Baltimore would qualify with over 1% HIV prevalence. So when we think about communities, sometimes it's helpful to sort of drill down to a particular sub-community of a larger one. So one thing that I've been thinking about so this started when I was a graduate student at Hopkins, primarily, as I mentioned, working in sub-Saharan Africa, and then later moving into the US. Oftentimes our work is in low-income or financially distressed populations or settings. And why is that? Why is it that poverty and financial distress and limited economic resources, why do they adversely affect health outcomes? And in terms of public health and community health sciences, should we be doing more to reduce poverty as part of our public health approach and as part of our work in low-income communities? So it's one thing to focus vertically on a health outcome or a behavior outcome. I think it's another thing, we've talked about structural and sort of low agency interventions, and can poverty reduction be done so? And in low-income countries, we know there's a long tradition and literature and evidence base of microfinance initiatives, less so here in the US. So in terms of linking back to HIV prevention, one question has been, does economic disadvantage contribute to HIV risk? And just to give you a little sense, so we do know the answer to this question in many ways. This is sort of a description of the web. It doesn't identify the spider, so the cause, but these are associations from a lot of observational data. We know that HIV prevalence, this is in the US, in low-income urban areas is 2 to 5 times higher than the national average. We also know that unemployed individuals or those living below the poverty line are 2 times more likely to be infected, and that African American youth, so primarily young adults, not adolescents, represent an increasing number of the urban homeless and unemployed population. And more and more, so looking at those associations, more and more, there has been some qualitative and quantitative research to think about sort of what are the mechanisms or what are the causal or behavioral pathways, and several potential causal pathways have been suggested. So in terms of direct impact, in some, it's been thought that there's a short-term imperative among poor youth to engage in high-risk activities to support themselves, to essentially earn income. And engaging in those high-risk activities actually leads to increased HIV vulnerability. So what does that mean, actually? Sometimes it varies between young men and young women. For young women, oftentimes that's operationalized through cross-generational and transactional sex, so exchanging sex for money or drugs or housing in the population that I work with. And among young men, that can also be the case where they're exchanging sex for housing and financial resources. But it can also be in terms of engaging in theft and even the illegal drug economy as a means of acquiring income to survive. And we know that a lot of those activities are associated with increased violence, both sexual violence and substance use, incarceration, and those also lead to higher HIV risk. And so those are sort of direct causes that relate to not having sufficient resources, financial resources, and trying to supplement their income with high-risk activities or high-risk income earning activities. There's also been more recently some study around asset theory, which some of you may have heard, and also there's a new field of behavioral economics that tries to integrate psychology and economics in thinking about what is the psychological impact of financial distress and how we make decisions about engaging in positive or negative behaviors. And so when it comes to asset theory, there's this notion that financial distress due to either material or psychological poverty leads to a loss of hope and a loss of motivation and a loss of agency that actually diminishes a person's hope or belief or motivation to protect themselves against HIV. And actually observed this in some qualitative work that we did that I'll talk a little bit about as I go, with a young man who mentioned that he didn't care so much about acquiring HIV. There was so much sort of trauma and stress and anger and being financially isolated from what he wanted to do in terms of being financially stable and autonomous. The HIV risk and mortality and morbidity was sort of irrelevant in terms of just the amount of capacity he had to prevent that. And so in thinking about how do we then develop an intervention, not just sitting from my desk, but how do I actually get out into the community and see whether or not this is a relationship that bears play in Baltimore, and what do youth themselves propose as an intervention. In 2015 and 16, actually, it started in 2014. We did 40 qualitative interviews with young African-American young adults and adolescents who were recently homeless within the last 12 months, who were out of school. So with the exception of GED training, they were not enrolled in any sort of vocational or associate degree training programs, and who were either unemployed or underemployed, and underemployed meaning working less than 10 hours a week, and who had recently engaged in sexual risk behaviors, whether it be having sex while drunk or high, or engaging in condomless sex, or having a partner who was engaged in a sexual risk behavior. And just to give you below some of the data that we had, quantitative data, so we had a short quantitative survey that complemented our qualitative interviews. So 42% of them did not use a condom at last sex, and that was just one of the sexual risk behaviors. 30% reported ever trading sex, and 90% reported that they had a peer, a similar homeless, out of school, and unemployed or underemployed peer who had exchanged sex for money or resources, drugs or housing. So then the question is, what is the role of microeconomic interventions for HIV prevention in young men and young women? And by microeconomic, what I mean is an intervention that really tries to reduce poverty or improve the financial stability and autonomy of either an individual or a family or a couple, but something certainly at a community or a sort of local level as opposed to a broader macroeconomic level. And you've probably seen some of this through the economic empowerment literature within HIV that's been developing over the last 10 years. And so this diagram here sort of gives you a range of the various microeconomic interventions in the literature that have been tested. Most of these have been designed and tested in low-income countries, not in the US, not among low-income communities here in the States. There's this sense that, and there are many barriers which I can discuss later, but there's this sense that they're not feasible here. So in either case, that can be asset transfers, whether it be cash or in kind or housing. It can be improving access to financial services in terms of banking and access to credit and loans, vocational training. I have microenterprise highlighted there in blue because that's what I'm going to talk about in terms of the project that we are working on in Baltimore. But others include the last two there, workforce development, which is really focusing on improving job skills and employability. So their ability to secure employment, and then finally asset protection, really helping as part of this economic empowerment, having a microeconomic intervention that tries to provide access to insurance and legal services and savings that will help them mitigate financial distress and economic shocks when it comes. And so how do we take these kind of interventions in terms of HIV? They can really be applied to multiple health outcomes, but we're doing it through HIV. And our prevention goals really try to target economically motivated sexual behaviors. And so
just a quick question. So
that
you're aware,
includes decreasing financial reliance on sexual partners.
Say next slide,
A
so
lot
we
of
can advance
times,
you over here, right?
the
Okay, great.
ability
Yeah,
to
just wanted to
negotiate
double-check.
condom use or HIV
Awesome.
testing
All right,
or
yeah, so
even
you should be
reducing
coming
number
up
of sexual
in the
partners
next 5 minutes
is
or so.
limited because you're relying on those partners
thanks.
to provide financial support in some way or another. So by decreasing the financial reliance and increasing their ability to negotiate and make safe decisions around sex, even increasing their sexually safe alternative sources of income, and decreasing financial distress, which discourages positive behaviors, and then finally increasing their income, which is available for uptake of HIV preventive services. So I wanted just to highlight briefly some of the work that we did in 2014. This was published a few years ago. This was actually a systematic review since we were looking at how do we then develop this kind of intervention for the US. So we did a systematic review. We looked at over 2,000 citations and found only six papers in the peer-reviewed literature that actually described any kind of microenterprise or entrepreneurial education initiative among US or American youth. We also looked at clinicaltrials.gov to see whether or not there were any registered clinical trials that were using a microeconomic or microenterprise intervention. We identified six, but only all six of them were in low-income countries. So we really saw that there's a dearth in terms of programmatically and as well as empirically of testing and adapting and implementing these kind of programs and then generating evidence and hopefully practice and policy at the community level, at the household, couples, and individual level. So that's what we set out to do. I'm the PI of that study, and it's a KO1. It's, as I mentioned, we've spent the last 2 years or so doing a lot of the development work to get this off the ground. There are three aims of the study. The first we've completed in terms of this is a pre-design phase. So what we've proposed to do is enroll about 80 youth and randomized 40 to intervention and 40 to control. The intervention is a 26-week training that involves micro grants of $1,000. So $1,000 is not very much money, but it gives them an opportunity to develop a business plan and either work alone or work in a group up to 4. And they are partnered with a Baltimore-based business owner, some who are African American, some who are not, who work with them on the occupational area that they've chosen, whether it be photography or catering, et cetera. And part of when we're doing our formative research, asking youth, would you be interested in some sort of entrepreneurial type intervention, and would you want HIV education that's included in that? There's a real interest in having a network and also having continued engagement beyond the in-person sessions. And so we decided to add a text message component, and we brought in a behavioral economist to actually help us do some qualitative research around how do we create some text messages that get at some of the issues that the youth were describing. And so the first aim was to actually qualitatively examine economic factors associated with HIV risk from the perspective of youth themselves. And we based that on 3 BE principles, behavioral economics principles. Delay discounting, so we asked youth to describe what happens if they want to engage in sex with someone, but they don't have a condom on hand or the partner doesn't. How long are they willing to wait? Oftentimes with delay discounting, we delay rewards that are in the future, and so we're more willing to take on risk presently. Loss aversion, so getting a sense, typically humans experience loss more severely for the same amount as they would than they would the same amount as a gain. So losing $100 for you is actually more troublesome than gaining $100. You experience it more severely. So you try to better understand how bad is it to lose your HIV negative status. How loss averse are you to that, and how loss averse are you to losing housing or financial stability or losing your job? And then trying to develop text messages that try to motivate them and support them to think about rewards that are in the distant future, but also think about rewards that are in the near future, and to minimize the sort of the cost that they might be experiencing in the present. And then finally, the endowment effect. So oftentimes with the endowment effect, if you own something, it's more important to you. So a lot of youth expressed, this was in our qualitative interviews and focus groups, expressed feeling so frustrated with low-wage jobs. So quitting, like acquiring a job at, say, a local McDonald's, and then quitting after 3 or 4 weeks. It just felt so disempowering, so frustrating. They felt disrespected. They felt like they weren't their own boss. And so this entrepreneurial or microenterprise intervention is also meant to give them something that is aligned with their interest and their skills. Many of them are already engaged in the informal sector. So it aligns with their interests and their skills and gives them something to own. And so we're trying to also develop text messages about owning not only your financial health, but owning your sexual health, and thinking of that as an asset that you want to protect not only for yourself, but within your sexual network and within your community and within your household. And for homeless youth, this idea of community really actually is within that. So we recruit them from 2 youth organizations that work with homeless youth, so community is within that organization, but also among peers that experience the similar residential instability. So the second aim then is to take lessons learned primarily in Asia and sub-Saharan Africa that have tried these interventions for HIV prevention, primarily with women. So the evidence to date for low-income countries is that this does not work with young men. If you give men opportunities to earn extra money, they do not spend it on families and their children. We're hoping to apply the empowerment model to disempowered young men here in the US who want to be want these same income earning opportunities and want to be engaged positively in their communities. So AIM 2 is all about adapting those models to fit in the US, and then AIM 3 is actually launching this, we hope, knock on wood, next year in 2018. So I'll stop here. I was told I had 10 minutes, but I'm more than happy to answer any questions later. Thank you.
All right, so he's going up there to introduce you now. Okay, bye.
Okay, one last presentation and then discussion, and we will not go beyond 4 o'clock, so don't worry. We will end by 4 o'clock. Ashley Butler. Ashley Butler will speak about perspectives of minority youth with type 1 diabetes and their parents on diabetes care responsibilities, tailoring a family intervention to improve glycemic control. And she's going to come to us electronically, I'm told, and that's all. Looks like I'm getting head nods. It's all okay. Ashley Butler is assistant professor of pediatrics, Baylor College of Medicine. She's a clinical child psychologist at Texas Children's Hospital, and she directs a health disparities research laboratory. Her work focuses on racial and ethnic differences in healthcare and health outcomes of children's mental health, childhood obesity, and pediatric diabetes, as well as effective behavioral and psychosocial interventions. She's an NIH NIDDK K-12 scholar and has received support from the National Institute on Minority Health and Health Disparities. With additional NIDDK support, she's currently testing a community-based behavioral intervention to improve glycemic control among African American and Latino school-age children with type 1 diabetes. And she's also testing a peer-delivered intervention for parents to prevent obesity among African American and Latino preschoolers. Although we are very happy that she was willing to present remotely, unfortunately there won't be an opportunity to ask her questions in real time online, although you could certainly tweet questions, and I'm sure we could put you in touch with her as well, and that these topics will come up as our discussant leads the discussion later. So, Ashley, I feel like, I don't know where, oh, there, it looks like it's happening.
Good afternoon, everyone. Unfortunately, I'm unable to be there this afternoon, but I want to thank the folks there in Boston so much for their flexibility in allowing me to present this work remotely. And so first, before I get started, I just want to note that I'll be talking about type 1 diabetes and just want to distinguish it a little bit from type 2 diabetes, which is what's most commonly diagnosed among racial and ethnic minorities. Type 2 diabetes used to be called non-insulin dependent diabetes, and this type of diabetes is most commonly managed by taking a pill initially, as well as through lifestyle changes like healthy eating and getting adequate exercise. But in the research that I'll be talking about today, the focus is really on racial and ethnic minority youth with type 1 diabetes, which used to be called insulin-dependent diabetes. So youth with type 1 diabetes, really their bodies do not make insulin, and so they're dependent for life on either daily insulin injections or daily insulin delivered through an insulin pump. And so meeting these daily insulin needs multiple times per day is just really part of a really complex set of daily tasks to manage their condition. The other tasks include things like monitoring blood glucose levels multiple times per day. They have to pay really close attention to their physical activity and their nutrition. And it's really that all of these tasks together are really important to maintain healthy blood glucose levels in order to prevent the long-term complications of diabetes, like amputations or kidney disease. So you can advance the slide. Okay, so I see it. You can stay on this for now. So we know that really focusing on African American and Latino youth with type 1 diabetes is important because there's this strong and consistent empirical data that shows that they have disparities in type 1 diabetes outcomes. They have poor glycemic control, as measured by hemoglobin A1C, where the higher values indicate worse control. They're more likely to experience diabetic ketoacidosis, which is a serious complication of diabetes that requires hospitalization. And really recently, there's been the publication by the Center for Disease Control showing that a really troubling finding that African American youth in particular are twice as likely to die from diabetes-related complications. And next slide, please. And we also know that African American Latino youth, in terms of health care disparities, that they're less likely to receive advanced technologies to help them better achieve better glycemic control, such as the insulin pump. And next slide, please. And so really, overall, researchers, there's been a lot of documentation of the existence of these disparities in health outcomes in healthcare, but really there's been little exploration of any of the potentially modifiable variables for these disparities in type 1 health outcomes. It's always assumed in discussions that disparities are due to low socioeconomic status or lack of access. But a lot of the studies show that even when you control for those factors, that the disparities are still there. And overall, few studies really focus on factors to change or prevent the disparities. We know that there's a large body of literature that shows that when there's a gradual shift in care responsibility from parents to teens during late adolescence, that there is actually protection against poor diabetes outcomes. And so we also know that in the general child development literature, there's also documentation that African American and Latino parents tend to encourage independent behavior in younger children before they reach adolescence. So it's possible that the promotion or high levels of independence in diabetes management in African American and Latino youth can contribute to poor health outcomes. So you can go back to the next slide. I saw that you can switch it now. And so because there has really been little research that explored diabetes care responsibilities in racially and ethnically diverse youth, what we aim to do through the K-12 project that I've been funded on is to determine really what are teen and parent perspectives on how diabetes management tasks are divided in their families, and to explore racial and ethnic differences. Today, what I'll focus on are the results from the teens. Although we conducted the study with both parents and teens, due to time limitations, I'll focus on the teens today. But overall, the overall goal of this work was to really try to identify potentially modifiable targets of interventions to help address the disparities in diabetes outcomes. Okay, next slide. So what we did was we recruited teens who were ages 15 to 19 years old, who were established patients at our diabetes care center within Texas Children's Hospital, and the teens had to have diabetes for at least 1 year. We screened the medical records to identify potential participants who had upcoming appointments, and then we actually approached them for recruitment during their diabetes appointment. And then we completed qualitative interviews with them either after their appointment, after their diabetes appointment was done, or if they preferred to do the interview over the phone, then we were able to conduct it later via telephone. And next slide. The interviews were conducted by our research coordinators. They lasted about 20 minutes. And the types of questions that we asked were things like, what are their challenges to managing diabetes? What do the teens feel like they do well in terms of managing diabetes? We asked them to describe just their daily management of the condition, as well as how the diabetes management tasks are divided within the family. And next slide. And so we were able to recruit 30 parent and teen dyads, and we had roughly equal numbers of African American, Latino, and non-Hispanic white dyads. We had just a few more females participate than males. The average age of the teens was 17. Most of them had private insurance and were from families with married parents, and most had a caregiver who participated, whose education was having at least some college education or higher. We, in terms of analyzing the data, our coordinators used, we took a qualitative thematic analysis approach where we had written transcripts of the audio recorded interviews, and then we had the analysts read the transcripts through an iterative process, extract data, and then code the data, and then develop broad themes from the data. And next slide. So we were able to, so 5 themes really emerged when we looked at the data across all of the 3 racial and ethnic groups, in that the themes really ranged from the teen having kind of sole responsibility for their management to them having kind of equal or shared responsibility with their parent or caregiver. So I think to advance the slide, maybe one more time or twice so that it's on the slide with the results. And so what we found, though, was that, like I said, there were predominant themes, so that were different by race and ethnicity, where the non-Hispanic white teens reported that their parents were involved in management to some extent, either with there being kind of this equal or shared responsibility, or the teens were actually responsible for some tasks with some parent involvement. The Hispanic teens tended to report a less parent involvement, with their responses ranging from being solely responsible for management tasks to there being shared responsibility between the teen and the parent. And then finally, the African American teens tended to report less parent involvement, with them being either solely responsible for their management, primarily responsible, or the parents really only got involved in management when there was an emergency situation related to diabetes. And so the next slide, please. So on this slide, I put here a quote from a non-Hispanic white teen that really shows this kind of shared responsibility between the teen and the parent, where the teen says, it describes all the things that her mother does for her. Actually, my mom will figure it out for me since I'm getting ready for school and whatever, figures out my insulin for me. If I'm getting ready for school, if it's that time of year, then I figure it out. She'll help me fix my carb to insulin ratios whenever I go to the doctor. She helps me count my carbs. So does my dad. I don't know. That's pretty much it. They're trying to get me more into it so I'll know what to do. And the next slide, please. So this is the quote from the Latino teen who reports kind of this greater responsibility in management of type 1. I think when I was younger, it was mostly on my parents, and then I would check my blood sugars. I think now I decide what my carbs are, and I try to order prescriptions as much as possible. I think now as the shift towards leaving to college is coming up, we're trying to divide it more on my side. So maybe like an 80% on my side, 20% their side, or a 70-30, just to distribute more weight on myself. And the next slide. And then finally, this is a quote from an African-American teen who says everything about diabetes. I'm responsible for changing my site, staying on top of the insulin, knowing when I need to get my supplies, knowing when I need extra stuff outside of the supplies that they send, checking my blood sugar 4 times a day or more, handling the lows and the highs. When I can't, my mom helps me when it's when it's too low or too high and I get sick. Most of the time I have to speak for myself, like set up my appointment and make the calls and stuff. Next slide. And so just overall what we concluded from this, that it's possible that being more likely to have kind of sole or this primary responsibility for their care during late adolescence may contribute to poor glycemic control in Latino and African American teens. And that Latino and African American families might benefit from interventions that emphasize family teamwork in diabetes management and that aim to help parents more gradually and intentionally transition care responsibilities during late adolescence. And next slide. And so for future research, I think the first step, I mean, we have a sense that that the sole responsibility or having primary responsibility may be an important target of intervention, but before we could really understand exactly how to intervene, there's a need to really use additional qualitative methods to identify what are the obstacles faced by African American and Latino families in sharing responsibility in type 1 diabetes management. And so going back to one of the slides that I think was presented earlier today about the social ecological model, it's really, we've really couched this research in kind of relationships or family-related factors, but it's important to go kind of beyond that and look more at aspects of the healthcare system or aspects in the community that may be serving as obstacles to shared responsibility. And then with that understanding, there's an opportunity to develop and test more tailored and community-based interventions for families of children with type 1 diabetes, and really to prevent or to reduce the disparities by more parent-focused interventions that are delivered early after diagnosis before these patterns of responsibility really become entrenched and difficult to change. And the next slide, please. And so we actually were recently funded to do this work with myself being the PI on a DP3 that's funded through the National Institute on Diabetes, Digestive, and Kidney Disorders, which is the DP3 is an R01 level study where we will conduct in 4 years, we will try to adapt an existing family-based intervention that was an intervention that was developed for families of teens with type 1 diabetes for younger children. And in this project, we utilize and community engagement strategies and have a number of partners who will be both involved in the development of the intervention as well as the implementation of the intervention. And it's nice because the DP3 is different, it's R01 level funding, but it's different than most R01s in that it's a special funding that will allow us to both develop and pilot test the intervention. So we're able to bring together our partners from the Department of Public Health, from the mayor's office here in Houston, where they have some diabetes-specific programming that we can kind of utilize and help us to develop our intervention. There's a cooperative extension program here in Houston, as well as their diabetes care providers, including endocrinologists who are co-investigators on the study, as well as we'll bring our patients, African-American and Latino parents of patients with type 1 diabetes, and we also have a team of experts in health communication who have been involved in health communication messaging for racial and ethnic minorities who will help us to frame the study in a way that will increase the receptivity and interest and make sure it matches the needs of the community that we will be serving. And next slide, please. And so finally, in closing, I'd just like to acknowledge the grant that funded the qualitative study that I presented here today. As I mentioned, it was through my funding as a K-12 scholar on a K-12 that was awarded to Dr. Barbara Anderson. And then I'd also like to acknowledge the research assistants who were very helpful in terms of the data collection and analysis for this study. And that's all that I have today.
Thanks very much, Professor Butler. This is not a remark about Professor Butler, but about one thing I'm learning about community health sciences is that for us, apparently time is not linear, and it doesn't have limits. It just goes on. And so we have half an hour left to do an hour's worth of work. And what we're going to do is, I think we'll do 25 minutes instead of 30 for Professor Halpern's discussion. And so I'm going to ask the panelists, the two panelists, to come up and have a seat up here while I introduce Dr. Halpern.
Okay,
So
no problem.
Carolyn Halpern is professor and chair, maternal and child health, Gilling School of Global Public Health, University of North Carolina at Chapel Hill. Deputy director of the Waves 4 and 5 of the National Longitudinal Study of Adolescent to Adult Health, and as I struggle through that, I know why we all call it the Ad Health Study, program projects. With NICHD and NIDA support, her work in over 140 journal articles and chapters has focused on improving understanding of healthy sexual development and the implications of adolescent experiences for healthy adulthood, with an increasing focus on health and health disparities of sexual and gender minorities, and recent work reducing HIV risk in adolescents in sub-Saharan Africa. So let's welcome Professor Halpern. We'll go for about 20 to 25 minutes, and then I'll just take 5 minutes at the end to wrap up. Thank you.
Good afternoon, everyone. Thanks for hanging in there for this long but incredibly interesting day. I'm really happy to be here. I've titled my remarks, "Is the Past the Future of MCH?" Because at the level of the field, we build the future based on accomplishments in the past. But I'll also describe in a minute that in our current socio-political context, the past may again be the future. Further, for individuals, the past certainly contributes in important ways to future health and well-being, and a better understanding of those pathways is, of course, part of our work. So given the broad scope of MCH and the different possible directions that my comments might have taken, I really kind of struggled with this presentation, so I thought I'd offer a little levity and a quote from one notable leader, Dr. Catherine Janeway, who says, "Since my first day on the job as a Starfleet captain, I swore I'd never let myself get caught in one of these godforsaken paradoxes. The future is the past is the future, it all gives me a headache." So, alrighty, so as I noted, I just had to throw her in there, MCH is a population-based field, so the scope is very wide, and in fact, at the Gilling School, our mantra is MCH is public health. I think, virtually any public health issue is going to intersect with the population of women, children, and families in some way. So I think one helpful way to think about it is about the field, to sort of just set the stage, and it sort of accompanies the ecological model we've been talking about for the day. These are known in our department as Earl Siegel's circles. And to quote one of my former colleagues, Dr. Jonathan Koch, he points out that one can hop on board this life cycle go-round at any point and link common ground with colleagues in women's health, perinatal health, reproductive health, and children's health. The means to achieving optimal health and well-being for all children and women of reproductive age are just as important as the ends. So where have we been? In the U.S., the federal government has a longstanding commitment to help states to ensure the health of women women, children, and families. And historically, this has yielded some incredible achievements, thinking about just a few examples of immunization and the contributions to lowering morbidity, significant declines in infant and maternal mortality in the 20th century, better contraceptive methods that have led to smaller families and increased time between births, which ultimately leads to better health for women and infants. And closer to my own research in adolescent and young adult sexual health, there have been dramatic declines in teen pregnancy, birth, and adoption, largely driven by improved contraception. We've also seen important decreases in repeat teen births. And as this slide from the Guttmacher Institute illustrates, there have been increasing efforts to enact supportive measures for reproductive health. However, the present also includes some pernicious disparities and rising threats to both past accomplishments and the future. And I'm going to join Marjorie on her soapbox for a few minutes. There are still gaps in teen birth rates by race, ethnicity, and Dr. Butler just described the disparities that we see in type 1 diabetes. There are the rates of unintended pregnancy remain high, especially for women of color. And since 1987, trends in pregnancy-related mortality have been rising, not falling. And there are persistent and seemingly intractable race, ethnicity disparities in maternal and infant health and in preterm birth. And that was really nicely highlighted by Dr. McCloskey's presentation. So policy changes threaten to maintain these disparities or maybe even reverse some of the achievements that we've seen. And I tried to illustrate that in some of these headlines from the fairly recent past. I want to draw your attention to the last two because they're especially important to me. But, when the Planned Parenthood headline about this 900% increase in IUDs, I can tell you that the day after the election, 3 of my students went out and got IUDs because they were afraid they wouldn't be able to get them again. So you can see the depth of concern that young people have. They really feared the worst. So. And then despite the positive efforts to support reproductive health that I talked about earlier, access to abortion is also being threatened by increasing numbers of state restrictions. And then when you combine that with threats to teen pregnancy prevention efforts and access to effective contraception, and the still promoted but ineffective, and some have argued unethical, abstinence only until marriage sex education, there is certainly cause for concern. And some of you may know that recently OPA discontinued its funding to the Guttmacher Institute to track these kind of policy trends over time. But it's not just the political climate. Let's take the case of vaccinations, about which there seems to be increasing skepticism due to distribution of erroneous research findings. This slide shows the decline in vaccines for mumps, rubella, measles, and polio among kindergartners in Washington state. In Seattle, the polio vaccination rate of 81.4% is lower than in Vermont. So are we doomed, again, to fight public health battles that we thought we'd won? Is the future the past and the past the future? So I want to go from Captain Janeway to another notable and formidable leader. No, I don't think we are doomed. I want to quote Donna Peterson here. Data creates information, which generates knowledge. And once knowledge is apparent, it is difficult not to act upon that knowledge. Now, that may not quite ring true to everyone these days, but education, evidence, and advocacy based in the community, I think, really are the key paths forward. So what does that mean for MCH specifically? How can we try to move the needle? One important element, I think, is that's clearly tied to community health is a more effective dissemination of sound evidence-based MCH findings and engagement with communities to make sure that the findings are accessible and properly understood. So giving away MCH science has always been challenging, and I think it's even more so now with social media and the rapidity with which things kind of get out there in the cyberspace. And it's easy for things to get misinterpreted. And vaccinations and autism are one example, but I was, along these lines, I was struck by this headline that I came across. I didn't realize that fish were self-aware and had gender identities, but apparently they do. So, okay, so one is better management of dissemination and explanation of scientific findings to try to move our field forward. I think continued investment in MCH leadership training. There's a lot of concern these days about the MCH leaders of tomorrow, so I think that investment is very important. Improved translation from basic science to practice, and translation that includes implementation, evaluation, and improvement. And I wanted to applaud Dr. Jennings for her structural intervention work and the wonderful idea of taking things that have worked in low and middle income countries and giving it a try in the US. I think that's very innovative. Capitalizing on big data and systems approaches, applying a life course perspective to research and program development, implementing more holistic approaches to biopsychosocial determinants of health and development, and to support all of the above, supporting and rewarding interdisciplinary training in health science. As we know, that is sometimes a challenge, especially for junior scholars. Dr. McCloskey made a great case for the importance of life course in her presentation, and a great example of how big data can inform our work and how systems often don't intersect in ways that benefit the health of women and children. And your conference sounds very exciting, too. So I wanted to just give you one example of how we might apply a life course perspective to understanding biopsychosocial determinants of health and development in a more basic research kind of context. And so, no surprise, I'd like to tell you a little bit about what we're doing in AdHealth in the Wave 5 program project that we're in the middle of now. You may know that AdHealth includes a nationally representative sample of more than 20,000 adolescents in grades 7 through 12 originally. It was a very context-oriented study from the beginning, so the idea was to really map very well what the social and physical contexts are that adolescents are growing up in. This is its sampling structure. I won't go through all of it, but I just wanted to give you a sense that it is complex. It's a school-based sampling design that included 132 schools, and the design does include populations that were oversampled, so there are opportunities to look at groups that are often too small in other studies to take a look at. And then this slide shows the longitudinal study design for AdHealth. We've completed 4 waves of interviews so far and biomarker collection, and right now we're in the field for Wave 5. And at this point, we have a wide range of survey, contextual, and biomarker data for individuals who are in the 7th through 12th grades, and they're now age 31 to 42. So this has been an interesting journey for me as an adolescent health researcher. I have the privilege to be the PI on the only substantive sub-project within the Wave 5 program project, and it's called Precursors of Chronic Disease. So I have to tell you that it was kind of weird to write a grant application about precursors of chronic disease when that's not really where your history lies. But I did learn a lot. It was a great learning experience, and I really do feel like the data that we are generating are going to provide a long-term prospective look at life outcomes that can ultimately be used as an advocacy tool for adolescents. So in this project, and I'm not going to stay on it too long, but we want to try to test 3 life course models of developmental origins of disease. So these are the fetal origins model, which basically says that environments and events in early periods essentially permanently change the organism. So it's a very deterministic kind of model. The cumulative growth model postulates that the pattern and growth of adverse biopsychosocial experiences and environments accumulate over the life course, so it's an additive model. And then finally, the most complex is what we're calling the pathways model, which indicates that biological factors and early environments and experiences interact over time to put people on distinct pathways to later behaviors and experiences and environments. So wave 5 was motivated by what we saw in wave 4 when respondents were in their 20s and early 30s. There was really an explosion of chronic disease and precursors of chronic disease. So in this project, we wanted to extend that idea of sensitive periods beyond just the early prenatal or fetal or postnatal period, because that's what most of the work in this area has focused on. So we made the argument in this project that adolescence is also a sensitive period and a critical period. As you all know, there are profound physical and neurological changes. The cortical and limbic circuits are completely remodeled as they were earlier in life. So there are multiple pathways that can change decision-making and behavior into adulthood, thus making adolescence an important period to look into. I can't, data collection's ongoing for wave 5, so I don't have any findings to share with you, but I can share with you a couple of examples from existing AdHealth data that shows the implications of adolescence for selected aspects of adult health. So in wave 4, 26% of our respondents had hypertension. And the scary thing was that most of them didn't know it, and of those who did know it, they were not on medication. So remember, these are 24 to 32-year-olds, so that's really an extraordinary prevalence of hypertension in a sample this young, and it's a population-based sample, so it's a little scary. The AdHealth sample has documented the obesity epidemic in America's youth, and in adolescence, about 11% of our sample was obese. 6 years later, when they were 18 to 26, 22% were obese. 6 years later, in 2008, when they were 24 to 32, 37% were obese. So almost 4 in 10, again, at ages 24 to 32. Oops, excuse me. So this figure shows the obesity trajectory from adolescence into young adulthood and how it's associated with various selected measures of health and adulthood. It shows 3 groups, those who are not obese, those who become obese in the transition from adolescence to young adulthood, and those who were always obese or obese during adolescence and young adulthood. And as you can see, the more time in that sort of obese status that someone has, the higher the likelihood is that they will, even at this young point in their life, have diabetes or hypertension or high cholesterol or sleep problems. So it's not too early to start thinking about, the early contributions to chronic disease. So AdHealth is just one example of how interdisciplinary longitudinal research can help us understand the mechanisms that underlie health and disease. I think we're excited because by collecting additional retrospective information about childhood health and obtaining information about the pre- and postnatal period from birth certificate data, we're trying to pull together a 40-year-long life course picture of these individuals in our sample. I think these big data, along with the others that we've talked about today and others that we have not talked about, can really inform many and diverse community health efforts So I'm going to stop there so we can talk. Yes. So, questions for any of these panelists or for other things that have come up during the day that we would like to circle back to? Yes.
Thanks so much. I have sort of a reflection and then perhaps a question. One thing I've noticed just throughout the presentations today, and certainly represented in the MCH discussion, is the real focus on qualitative research and the use of qualitative methodologies to bring about, this was also definitely the case in the earlier panel on violence. And I wonder if we are doing, this is not a loaded question, but I wonder if we're doing an adequate job preparing our future public health practitioners in qualitative methodology. And I wonder if you have any thoughts on that.
Yes. Great question. I actually do have a thought on that. So I actually teach the Qualitative Research Theory and Methods course. It's the only methods and qualitative research course at Hopkins. And last year we had our largest cohort. So when I started teaching it, we had about 50 students. It's only required in the program within my department. So we have about a dozen departments at the School of Public Health. We're the largest school in the US, as you know. And within one department of a dozen or so, there are 4 programs. So one program within one department requires qualitative research methods training. No other programs or departments do. So we went from having about 30 to 40 students. Last year we had about 100 students. And some of those students were actually coming from the School of Medicine, the School of Nursing, and other departments. And there's increasingly been a big push to start thinking about qualitative methods the way we think about more quantitative methods like epidemiology and biostatistics. So many of our doctoral students at the dissertation level want to include a qualitative aim, but they're past their coursework and training, so they're sort of winging it, if you will, and sort of reading and getting a faculty member to mentor them, which is not the same as formal training. So I would certainly advocate for, I think we're at the stage in public health and community-based science when we're thinking about how much context matters. I think certainly all of my advisees I encourage to get qualitative research training as part of their formal and basic public health training.
I had a question for Dr. McCloskey. I was just thinking, clearly we fail a lot of women who are pregnant, but it also seems like pregnancy is one of those few cases where resources come together. And, so people sometimes refer to pregnancy as an organizing diagnosis, and makes it much unlike almost everything else where, all the medicines that someone takes get realigned, social services get realigned, you think about environment and so forth. Does that make sense to you?
Yeah. It does. I don't think this is working. Maybe I'll just speak up. I think it's absolutely true that all things come together in pregnancy, including from a policy perspective, right? That's where our resources are going. And I think that's one thing we're trying to point to, that is a very siloed approach to anyone's health. These happen to be women, but it's a critical period, so that's important. But we've learned so much about pregnancy is too little too late, to really start caring about women, given what Dr. Halpern just presented about early roots of chronic illness, what I talked about in the later roots of pregnancy-based roots of chronic illness. It's just too little. And so the question is, how do we take that hyper concern with women and extend it backwards and forwards?
And I want to, is this on? I wanted to just add to that thinking about maternal mortality, going farther back upstream, one of the other things that's happening is because of the increasing prevalence of chronic conditions, going into pregnancy is more difficult because the woman is coming into it in a different state of health than she might have been otherwise. So again, I think it speaks to the importance of not starting just at pregnancy, but going way back.
But I was thinking of it actually more as a positive model. So, for example, your ad health kids so your ad health kids that show up as obese or having high blood pressure, and that nothing's coordinated. It may get noted by somebody, but it seems like it's just an isolated event all by itself. So I was actually thinking of pregnancy more as a positive model, that it's an opportunity, a rare opportunity actually to organize things around what's going on with somebody.
It might feel, well, it is a positive model, but if it were to continue between pregnancies, for example, even if we were just going to take and not just be as episodic as it is. But I also just want to say that I was talking about healthcare systems, life course approach, but the life course approach also always is about the structural roots and, I just want to come back to the community engagement CBPR idea and ask ourselves, around these issues, we've talked about diabetes, we've talked about HIV, violence, these vertical ideas, these vertical issues. How can we come back to an engaged approach that takes on the socio-ecologic model all at the same time? People in the room, people at the table who are, in fact, even if it is vertical, let's say diabetes, really concerned with the food industry and structural roots, microeconomic opportunities for youth. In other words, I know this is the very big picture question, but how can funding and how can our own research, our academy, bring people together around similar concerns using the community health model, socio-ecologic model?
And I'll just add to that. So it's interesting that you brought up the idea of pregnancy being an event to organize health services for women and families. So I actually got involved in microeconomic interventions because I was working in East Africa, where when a woman was pregnant as part of birth preparedness counseling, we would suggest that she set money aside for safe delivery in hospitals. And many women and couples were not able to do that because of needing those resources for other things, or not even having permission from their spouse or their mother-in-law, et cetera, to use those resources for obstetric care. And so then this idea of deciding during pregnancy to start saving money for medical services seemed to be too late for a lot of women, and more broadly a lot of families, and more should be done early on.
All right. Thank this panel very much. Yeah, of course, yeah. 4 minutes. 4 minutes. I put up here just notes that I took, and I'm not going to go through them because you're going to see how many pages there are. And these, I limited myself not to cool points that people made. It was sort of a separate note-taking exercise, but this was things that were relevant to defining community health sciences. And you'll recognize a lot of words that I've underlined as they go by from the day, from the various presentations. And I'm trying to think about how best to continue this conversation, because there's really not time to add to these now. I had some side conversations, and one leader in the field asked why we don't call it community and family health. I think it was a fair question to ask. there were a lot of features that came up that were prominent, and I'm still going forward here. So there are a lot of underlines, things that folks mentioned that are part of, I'm going back up now, of community health sciences. So where do we go from here? We might do another event at some point with a little bit more of the do, like I suggested at the beginning of the day. One thing I learned from the day is that the frame that I set out, that I wrote, has a lot that's missing or that could be added to, unless if I say that in a positive frame. There could be a lot added to that in the way that we think about community health sciences. I think I'm convinced still, though, that community health sciences exists, and that we ought to think about what to do with that opportune fact. Thank you all for coming. Very much appreciate it. Safe travels.